Great. All right. Well, good morning, everyone, and welcome to our first Global Health Tuesday webinar of this academic year entitled Harvard Humanitarian Initiatives Crisis Training and Preparedness Program. Thank you so much for joining us. My name is Kaylin Ostrowski, and I have the good fortune of serving as the Associate Director of Strategic Partnerships and Development here at the Global Health Institute. Today's session is part of our monthly Global Health Tuesday webinar series, featuring researchers and practitioners from the University of Wisconsin-Madison and around the world. Our webinar series highlights and discusses the complexity of global health challenges and the many kinds of expertise needed to address them. At UW-Madison, our foundation starts with the Wisconsin idea, a practice which takes knowledge and research out of the classroom and into real-world settings. Humanitarian efforts during crises are essential to mitigate catastrophic health consequences that have far-reaching impacts. As we have seen today and throughout history, challenges to reach and administer basic health needs to those in affected areas can be extreme and life-threatening. Today's discussion will explore the Harvard Humanitarian Initiative's approach to disasters and humanitarian crises. Before I introduce our moderator, a couple of quick housekeeping items. One, we are recording today's session and the archived video will be available on our website at ghi.wisc.edu. And we will be monitoring the chat, so please go ahead and share your questions and comments for the panelists there. So with that, let's get started. Today, we welcome Dr. Janis Tupesis as our moderator. Dr. Tupesis is a faculty member in the Department of Emergency Medicine at the University of Wisconsin's School of Medicine and Public Health. He is also an esteemed member of GHI's Advisory Committee and a former Associate Director of GHI. Dr. Tupesis is involved in projects with multiple academic institutions establishing graduate medical education in resource-limited settings. Since 2015, he has been working as a volunteer technical consultant at the Emergency Trauma and Acute Care Program within the World Health Organization. In 2018, he began working with the World Bank and Association of African Universities on advancing the African Centers of Excellence for Development project. Dr. Tupesis also serves on multiple international global health education committees and is faculty co-advisor for UW-Madison's engagement with the United Nations Development Program, Engineers Without Borders, and other partners focused on facilitating capacity and system strengthening in low and middle income countries. Welcome, Janis, and thank you so much for your leadership. I will now hand the webinar over to you. Thank you.
Awesome. Thank you, Kaylin, for the warm welcome. It's really great to see so many people this morning. I'm really pleased to see so many of you joining us on this timely conversation on humanitarian efforts. I'm even more pleased that the two speakers today are dear friends of mine. We've had a good chance of working together for a very, very long time. And so I warmly welcome them to the University of Wisconsin-Madison. So I'd like to begin with Michelle Niescierenko. Dr. Niescierenko is a pediatric emergency medicine and public health physician and the founding chair of the Global Health Program at Boston Children's Hospital, as well as the director of the Children in Crisis Program at the Harvard Humanitarian Initiative. The Boston Children's Global Health Program is partnership-based, working to improve child health through research, program implementation, and education globally. She has extensive experience in pediatric care, public health, and health systems building with host country governments in more than 30 countries on 5 continents, as well as with the World Health Organization, the World Bank, the US CDC, USAID, and various non-governmental organizations. Her career focuses on building sustainable systems in fragile economic, humanitarian, and conflict settings, and includes work, really substantive work in Liberia for very, very many years during the 2006 to 2017. It was instrumental in the 2014 to 2017 Ebola outbreak. She has done work in advancing advanced life support training to Palestinian hospitals in the West Bank and Gaza, assessing hospitals in northern Iraq after the liberation of Mosul, implementing neonatal care protocols in Indonesia, and developing comprehensive emergency care for more than 100 million people in Bihar State. A really interesting project that she's doing right now too is she's working with the Native American tribes right now in the Lakota, Nakota, and Dakota tribes in South and North Dakota. So we really welcome Michelle, and thank you for joining us. Another dear friend, Sean Kivlehan. Sean Kivlehan is the director of the Lavine Family Humanitarian Studies Initiative at Harvard and the director of the Emergency Health Systems Program at HHI. He's an assistant professor at Harvard Medical School and is in the Global Health and Population at Harvard Chan School of Public Health. He's an emergency medicine physician at Brigham and Women's Hospital, where he serves as the director of the Global Emergency Medicine Fellowship and has served as a consultant to the WHO, was a New York City paramedic for 10 years, and really works to strengthen emergency care and quality access throughout the world through innovative partnerships. So we really welcome both of you guys and look forward to your discussion. So I will turn it over to you.
Thank you so much, Janis, and thank you to the Global Health Institute for hosting us today. I speak for both of us when we say we're very honored and excited to be here and share our experiences with you. So Michelle is going to pull up the slides, and I'll start, and then we'll be doing this together, going back and forth a little bit. I think one of the great things that you'll see of what we've been able to figure out in our work is a way to partner really effectively between us and between our institutions to achieve some pretty powerful work. So I'll start by talking a little bit about Harvard Humanitarian Initiative and just give a very brief overview of what is HHI and what is its mission and values and vision, and then we'll go a little bit into specific programs that both Michelle and I run in HHI, and then after that we'll give several examples of work that we have done in the past or are currently doing, and we specifically chose these examples based to really demonstrate how we work with different partners in different ways and in different parts of the world in different ways. So hopefully it will give you a good idea of our approach to this work, and then we look forward to hearing questions and having discussion and learning from all of you. So Harvard Humanitarian Initiative was started just about 20 years ago in Cambridge, and it is designed to I think of it as it's an academic think tank for humanitarian action. So the Harvard University, like any other university, is sprawling and large and brings together thought leaders from all different disciplines. I come at it from a healthcare and public health angle, of course, but there's people in law, there's people in policy, development, and on, education, on and on and on. And what HHI does is try to bring those people together in all of these different fields of knowledge that are thinking about humanitarian issues, get them at the same table so we can look at the challenges facing humanitarianism and try to solve them from unique angles and bring these different perspectives together. So in the university, it sits as what's defined as an interfaculty initiative, and this brings together representatives from the 13 schools at Harvard, and then also from the healthcare side, which Michelle and I are obviously as physicians embedded in. It brings together all of the Harvard teaching hospitals. These are the several hospitals that are affiliated with Harvard for their education of their medical students, includes my hospital, Brigham and Women's, and where Michelle works at Boston Children's and several others. So, and it tries to serve as the humanitarian hub at Harvard. The mission is to really advance humanitarian knowledge, to take an evidence-based and academic lens to humanitarian action and look at all the problems that we're all familiar with, all the different challenges, and there's a long list, and say, how can we apply our academic rigor to this question to try to find more effective ways to help people in need? And from those different perspectives as I described. And our vision is that with this effort and this work at HHI and at other similar institutions around the world, that humanitarian aid will be based on scientific evidence and will provide the most effective aid to people around the world, which is a lofty goal, but I feel like it's a worthy one. And working with such a diverse group of parties is what makes it so interesting. This is our why. So this is some data and screenshot from the current Global Humanitarian Needs Overview that's published by UN OCHA every year. And this is the latest numbers that came out in December. They updated every December. So this is the 2024 plan. And as you can see, there's identified for humanitarian action plans, there's roughly 300 million people in need. And of that, only less than 2/3 are targeted for a variety of reasons. And you can see the financial requirements, which are daunting. And these are the global needs. The countries that are highlighted in red here are countries that have current active humanitarian response plans in the world. So there's 30 of them right now in varying forms, and these are our defined response plans by the UN system that structure humanitarian aid coordination and response for different parts of the world. And we'll get in a minute about how this feeds into our work. But before we get into the coordination aspects, which Michelle will talk about in a little more detail, I just also want to bring everybody's attention to just the scale of the need here. And here's the past 15 years almost, and you can see that the needs have grown and changed dramatically just since 2010 in this graph. This graph is also from the Global Humanitarian Needs Overview, and it's a report I encourage you to read if you're interested in this space. Displacement is one of the large drivers of need of humanitarian action. Displacement happens for a variety of reasons, conflict being the largest driver. And we can see just in the past few years, first, the war in Ukraine, which is one of the examples that we'll talk about in a little more depth in a few minutes. Then the Sudanese conflict that continues. And now for the past year, the conflict in Gaza and West Bank, and now which is expanding even further over recent months. So we track this and we see the problem continues to grow, and that's why our work continues. So I'll turn it over to Michelle, who will talk a little bit about how this is all coordinated and structured and how we fit into that process.
Thanks, Sean. So the UN system is the sort of primary caregiver of humanitarian settings. And so the system functions, this is sort of one of my favorite graphics. It sums up a very complicated system in just one picture, which is what ER doctors like. It's the loop on the bottom kind of talks about the cycle of, before an emergency, trying to prevent, mitigate disaster or conflict preparedness, and then really the disaster piece. And the disaster, as Sean mentioned, could be war or conflict. This also relates to the system gets activated for famine or climate-related hazards. So some of the typhoons, flooding, things that we see that are more natural disaster at a very large multinational scale. And then hopefully once a disaster is over, or there's a response and then a recovery and a reconstruction. And so this disaster wedge of the pie, or sort of the loop, is where we focus. And so in a humanitarian emergency, there's a very structured system that's not always easy to see. And so it's something that I would encourage you, if you have interest in the humanitarian space, there's a number of open online courses that describe this system in detail, which I'll mention in a moment. But essentially, there's a central humanitarian coordinator designated, and he or she interfaces at the disaster leadership level with resources from outside the disaster coming in, then also oversees what we call the cluster system, which is where every sector, things like education for children, food and food security, health, nutrition, protection, meaning protection from abuse or trafficking or other harmful aspects of especially conflict. Each cluster has a leader, and within each cluster, there'll be a group of responders. And these responders are often local organizations, so the people on the ground who are usually there first and are acting first, the international community that comes in, so NGOs, other UN agencies, other countries, the Red Cross, Red Crescent societies or movement partners. And so each cluster, so in our space, the health cluster, there's a leader, and that leader's job is to try to help coordinate all the groups providing response so that as many needs as possible are met. It's often that not all needs are met, but the goal is to try to coordinate so there's as much need coverage as possible with little duplication. And so we work very heavily within this system in order to play a role that's coordinated amongst other responders and really enhancing what response agencies are doing. Some great resources if you want to learn about the cluster and the humanitarian organization system are the online course Building a Better Response, which was a joint effort between HHI and IMC, USAID, and a number of other partners. And then there's also the WHO Open School, which also has its own course on the cluster system. And so the program that I work with at HHI that brings pediatrics into the humanitarian setting is called Children in Crisis. And our goal is really to be the academic partner to support NGOs, government agencies, other academic institutions working in a humanitarian context to support the needs of children, making sure that translation of research, knowledge, technical assistance is going to translate into action. And so really timely, effective, and sustainable programs that support the needs of children. Our program goals are really around defining this needs. Children in humanitarian settings are often a little bit of an afterthought, and data collection methodology is not always great at defining what they need, since it relies on self-reporting at times. Our goal is to develop and implement educational interventions that help agencies provide better services and better care for children, and then contribute to the policy and advocacy of integrating child health and human rights into the delivery of humanitarian programs. And so our work focuses on implementation. So we do work directly in the field, providing services with different partners, as you'll hear about in a moment. We do focus on research, trying to understand the effects of humanitarian settings on children. Education, both education for children, so school-based programming, which you'll hear about in a moment, but then also education of practitioners who are going to care for children. Many times in different settings, you may not have either a pediatrician or a specialized pediatrician, and so providing the needed resources there. And then again, the policy and advocacy pieces of it. I'm going to turn it back over to Sean to talk about the emergency health systems.
Thanks. So the main program that I work with, and the way HHI is structured is there's a number of different programs focusing on different areas, and many of us, we float between different areas depending on the project. But as the program that I spend the majority of my time with is this one that I'll speak about for the next few minutes, which is the Emergency Health Systems Program. And this program we founded just about 5 years ago, so it's relatively newer. And we did that in response to a need that we identified. So the one thing that we realize in humanitarian response is oftentimes the response occurs, but then the transition to the development sector and the building of long-term resilience is not always there or always as complete as it could be. And similarly, in areas of the world that suffer from humanitarian responses, the effectiveness of the humanitarian response is often related to how strong the underlying emergency care system was before the humanitarian crisis occurred. So, because there's just a lack of resiliency there. So when we kept seeing this gap in our humanitarian response, we decided that there was an opportunity to focus on emergency care system strengthening in different parts of the world, and realizing that it's directly related to humanitarian response. So our mission is to strengthen emergency care delivery globally. We do this through a number of ways, through working with local partners and elevating the local voices and understanding what are their needs on the ground and what is the existing. The reality is an emergency care system does exist everywhere. It just may not be in a form that you recognize on first pass, in my example, coming from the United States. So we work with partners to understand their needs and try to build out these systems. One of our main partners that we've worked with over the years is the World Health Organization. And over the past decade, and Janis is actually been, and with many others at the WHO, what was first the emergency care program, and it's evolved into several different departments as it's grown. But mapping out what is an emergency care system, and this picture that you see right here is the emergency care system framework that was developed by WHO. And this is what we use to guide our system strengthening. And I encourage people interested in this space to go and take a look at the WHO website. It's a really excellent website with a ton of open access tools that you can use in your work that are very well developed and share with others. Many of them have been translated into multiple languages and validated in different settings. This is probably the most central document, I think. If you have one thing to look at, it's this. And I'm not going to go through it in detail, but I want to highlight one thing that there's three columns when you look at this image. The first is scene care, the second is transport care, and the third is facility care. And we use this to frame our response to system strengthening and how all of this ties into humanitarian response. And every single little image here is another area of work and focus and policy building that we work on with WHO and with all of our other NGO and governmental and academic partners around the world. That work over the past decade has evolved into a series of World Health Assembly resolutions. There was some focusing on trauma and anesthesia care over the past 15 to 20 years. And then in 2019, there was a really pivotal World Health Assembly resolution focused on essentially declaring emergency care and access to high quality, timely emergency care as a human right, tying it into universal healthcare movement. Then this past year in 2023, what is called the ECO resolution was passed, which is the Emergency Critical and Operative Care resolution, which I have here. I encourage you to read it, but I think this was a really transformative time for the recognition of emergency care and its connection to humanitarian and disaster response, and how these areas need to work together, bridging the humanitarian development divide to improve the access to care for people every day, from everyday emergencies like a car accident or a heart attack to major humanitarian crises, whether it's conflict or an earthquake or something similar. And you can see this infographic from WHO I posted on the left really just walks through some of the major opportunities for change here and what we can do with this. And this movement guides a lot of our work and a lot of our partnerships now. So now we'll transition into some case studies after we've given you a little bit of the framework of what is HHI, what are our two representative programs, and some of the general work, and give you some representative examples. The first one I'm going to talk about is Ukraine. So in 2022, the ongoing war in Ukraine that had already been ongoing for nearly a decade escalated significantly with the full-scale invasion of Ukraine in February. There were many needs, and in coordination with the World Health Cluster, the Global Health Cluster, and Ukrainian government and other entities, there were many needs assessments, and we coordinated with an NGO partner, International Medical Corps, to respond to these three needs that are highlighted here: trauma, clinical care training, mass casualty management, and CBRN. I want to highlight two important things about this. The first is that we responded to identified needs. So the first step is doing a needs assessment and coordinating with the bodies that do this, whether it's UN, OCHA, WHO, and governments, and making sure that you're working in lockstep through that cluster diagram that Michelle showed earlier. That's where these needs assessments come from, and that's how you really engage in this work properly and professionally. Second is HHI is an academic entity. And while we bring a lot of technical expertise and knowledge to the table, what we lack, or our blinder spot, is the operational and logistical capacity. And that's where our NGO or UN or government partners come in. So in this case, we partnered with International Medical Corps, which has an incredible logistical and operational network around the world, and in particular in Ukraine. And we've worked with them on many other projects. And these partnerships, this is one good example, is showing how we can complement each other. On the academic side, we bring the technical expertise. On the NGO side, they bring this operational expertise and the security logistics infrastructure that's needed to do this work effectively. And when people work together, you can really accomplish huge programs that otherwise neither entity would be able to accomplish alone. And I'll talk a little bit more about what we did. In response to those needs, we developed a whole range of programs and rolled them out, which this project actually just wrapped up last month in its main phase. So it was just a little over 2-year project. Overall, we ran about 330 in-person classes for different areas of trauma and CBRN and mass casualty care throughout the country of Ukraine. And we did it in a way that was sustainable from the beginning. And this is how we focus on all of our work, this phased process. Initially, the need is huge, and it involves bringing in a lot of instructors and experts from outside the country or the region. But as quickly as possible, we start transitioning to hybrid led. So in this project, which is educational, we identified the high-performing instructors from each of our classes and then started running instructor programs for them. And then you can see by phase 2, all of our courses were hybrid taught by Ukrainian instructors and our international instructors. As they got more experience, they began leading classes themselves, and we were just supervising and serving as a resource. So by phase 3, All classes were fully led by Ukrainians in Ukrainian language, and we were just there to provide technical support and expertise and more teaching about educational theory and how to be a good instructor. And then we created master instructor, third level, so they could create new instructors, partnered with local universities and created MOUs so that they could take these trainings and incorporate them into their formal curricula and ensure that they worked into the national curricula as well. And now in phase 4, we provide ongoing support through a series of remote meetings and spin-off projects. But this is, I think, a good model to think from the very outset. How can you meet immediate needs in the first days, but always from day one with a transition plan of how you're going to have an exit strategy that makes everybody supported, and that your work isn't just you show up and do something and leave and it falls apart. It's our responsibility to make sure that it's sustainable. This is where we went in that project. So over a course of 2 years, this is all the places, as I mentioned, about 330 classes were taught, 8,000 people trained. We created 700 instructors that now run classes. We've actually, now it's grown throughout the whole country because these instructors are teaching classes, and we can barely keep track of it, which I see as a sign of success when it has grown so much that we can barely they're doing it on their own, they're doing it effectively, and they're managing the quality through the university partners. So it's really been what I think is a success story of how this work can be done and how it can be done in even some of the most challenging zones. So and as you can see here, we really went everywhere, and there was a lot of focus on further in the East, and that this work can be done anywhere, whether it's a conflict zone or a remote setting. And a final word about a project like this in Ukraine, and we work in other similar contexts around the world, in particular conflict or post-conflict settings. And to do this work, there's a few requirements that have to be met. First, you should be coordinating with the coordinating entities like the UN, OCHA, the local governments, and making sure that your response isn't redundant and doesn't have gaps, that you're meeting an actual need that exists and you can fill that need, and that somebody else isn't already doing it. And if somebody else is doing it, maybe you work with them to ensure that it's more effective. And then once you have realized that there is a need and you can fill it responsibly in coordination with everybody, then you need to fill that need safely and responsibly, especially if you're working in a conflict setting. In this picture here, you can see one of our faculty members, Dr. Catalina Gonzalez-Marx, teaching in a bomb shelter in Ukraine, in Eastern Ukraine, and many of our classes were done there. And the reason we're able to do this work as an academic institution is because we partner with NGOs and other UN organizations that have incredibly complex and well-oiled security and logistic and operational infrastructure. We embed into their model for duty of care, where they take responsibility for us. We become essentially absorbed into their organization for all movements and their security apparatus. And that's I think gets to the heart of how we're able to essentially pull this work off as an academic institution. It's not that we're doing it on our own, but it's through a partnership model with partners who can keep us safe and make sure the work is done responsibly.
And then to share another case study, this work can also be done occasionally remotely. And so during COVID, we all remember that, we're all at home, global travel was shut down, but the humanitarian system continued to function. And so the WHO Global Health Cluster formed a COVID-19 task team, or TT, and that task team needed to understand what was happening in global humanitarian settings related to COVID. And so a team from HHI, we brought in, multiple languages. We had English, French, Arabic, and Spanish. And we did a study for the cluster where we did key informant interviews to understand in 6 different humanitarian settings: Bangladesh, Burkina Faso, Chad, Iraq, Nigeria, and Yemen. It was supposed to be 7, but it ended up being 6, to be able to understand in each case study, each country, what was happening with COVID? What were they seeing on the ground? What were their needs on the ground? How did this differ from what might be happening in more development settings where there's not ongoing stressors like conflict or climate hazards? And so our team took this study on. Obviously, to interview people in Bangladesh, there's a significant time zone difference. And so we had to really be flexible. These are folks who are in the middle of a conflict. I'm, comfortably sitting at home. So we were often doing, key informant interviews over Zoom or WhatsApp video or FaceTime. at 2, 3 o'clock in the morning to be able to align to their workday. Based on that, it was all qualitative data collection. We did a grounded theory analysis, had a double coding team until we saturated themes to then generate kind of what the specific needs are. This is the word cloud that came out of that. Obviously, public health measures reign true, which doesn't surprise anybody after several years of COVID. But essentially, what it did for the cluster was we really actually tried to dive into specifics. So this is an example bubble diagram of what the respondents in different contexts identified. So sort of a specific topic area, which was then sub-themed, which was then related to very specific interventions that were needed and then aligned to solutions that were coming from the ground level. And so it takes a lot of time. We did about 100 key informant interviews to do this study. If everyone takes an hour, that's 100 hours, plus all the analysis, plus all the writing to summarize it, put it together. So this was a huge scope of work, but really was the first information that the humanitarian system had to help start navigating their needs in humanitarian settings, what the COVID operational challenges were. There were a lot of cool innovations that different contexts were doing that could be shared between contexts. And then what kind of support should the global health cluster be rallying to support COVID in humanitarian settings? So there are opportunities to help with remote assessments at times. WHO and the Global Health Cluster often have studies going on and they need study advisory boards, people who are willing to read reports, read over data, give feedback, which is another way to get involved. Another example of a project we're doing is called The Thriving Child, which is a holistic school-based support in Tigray. And I wanted to highlight this project in particular because our primary partner is called OSAD, which is the Office of Social Services and Health Development, which is an Ethiopian NGO. And so we really try to be as local as possible whenever possible. And so OSAD has been operating in Ethiopia for 30 years, very well-respected organization, and was on the ground when the conflict in Tigray broke out. And so they were responding, months ahead of international agencies. And now as international funding dries up, and this is somewhat of a forgotten conflict, they continue to operate and operate very efficiently. And so in this project, we're working across sectors. So not just in the health sector, but in the water and sanitation or WASH, education and nutrition, as well as protection sector. And so this is a school-based intervention. And so the picture you see on your left is actually from a school in Tigray. Many of the schools were taken over by the armed forces and used as barracks or housing. And so most of the school infrastructure was destroyed. So you can see here the metal frames, the wood is gone. It was burned for firewood for cooking. And so there's no desks. You can see sort of the remnants of the electrical. Each of these school rooms had Wi-Fi, had monitor screens. These were pretty high-tech classrooms before this conflict that started 3 years ago. And so this population now, as the areas are being systematically deoccupied and sort of re-governed by the Tigray government, is leaving a massively traumatized population behind. It's the students, but it's also the teachers. And so we're looking at this area for intervention from actually a primary mental health lens. And so our idea is to support students by supporting the teachers around them, by creating a healthy school environment. All the kids are actually going to school because it's a safe gathering place. And there's not some of the usual barriers of uniforms or other things right now. And so our project that's going to roll out next month is to deliver a primary mental health intervention, where it's intervention to support the teachers themselves, support the teachers to support the students, and support the students, but then put in the components that enable sort of a healthy, both mentally and physically, school environment. So this would include doing school lunches, where we're doing community kitchens and PTA involvement for cooking, repairing water and sanitation equipment within the school system, putting desks and chairs and at least a blackboard in every classroom so the teachers can take pride in their work, and then creating menstrual hygiene facilities for girls so that they're not missing a quarter to 1/3 of their school time due to menstrual hygiene. And so this is entirely done with a local NGO. They're very integrated on the ground, know the communities, which enables us to be able to work, with the PTAs, with the school system very easily, but yet also feedback and coordinate in the WASH, nutrition, protection, and health clusters. Another mental health related project we're doing with a national organization is in Ukraine. We're working with the organization called Community Self-Help. They are a multi-sector organization. They do health, they do mental health, they do protection, they do some livelihoods or community engagement. And with this group, we're able to target the recently deoccupied areas along that eastern front of Ukraine, where here, if children are not injured or ill, they're not going to encounter a health worker, which means they're not going to encounter a mental health service, but they are going to encounter protection workers. And these are often their first interface. And these are people like caseworkers, fire and rescue, protection workers, registration of displaced persons. And so we're working to pilot a new package from UNICEF. So UNICEF, as the lead agency for children, can produce a lot of technical content, but doesn't always have the ability to pilot the content and see how it actually works in the field. And so we have taken their new package on mental health for protection workers and are delivering it through community self-help to 6 sites all along the Eastern Front over 6 months. And this involves both a training, but then a longitudinal case supervision. And so we have a combination of Ukrainian speaking and English speaking mental health supervisors who are doing virtual supervision with the workers to review cases, answer questions, to get to a level of competency to support them being competent sort of child mental health providers in the field. And then the last example I'll start and then I'll turn over to Sean is jointly, children and adults present to emergency departments. In most countries, children are not separated from adults in an emergency department. And so emergency rooms have to be ready to take care of everyone. And in Bihar, India, during the COVID Delta surge, ERs were drastically affected. We all saw the images on TV of India's overwhelmed healthcare system. And so through a partner care, which is a international NGO, their India branch wanted to take on improving the ER care in one of the most rural and the lowest sort of socioeconomic states in India, the state of Bihar. And so we worked with them to create a comprehensive intervention where we worked to identify what renovations are needed. How do you optimize that emergency room? Make sure there's bathrooms so the nurses will come to work at night. Human resources, making sure they're staffed appropriately, adjusting for volume, identifying education materials that can be taught just in time at the bedside through mentorship, and then targeting equipment. The state of India, the state of Bihar had funding to buy equipment. And so guiding them towards the high impact equipment like an EKG in every ER so you can diagnose MIs and refer, or other sort of core pieces of durable equipment. And so I'll turn it over to Sean to talk a little bit more about this project.
We picked this as our final example because we think that this is just a good example of bridging all the different work that we do. Adult and pediatrics, development sector, humanitarian sector, responses to an acute infectious disease outbreak, but also underlying system strengthening that's required. And as we all know, COVID really shined a light on any weak spots in our healthcare system, and particularly the emergency care system. And I always try to find the positive in any negative that happens in the world. And I think if there was a positive in COVID, it brought attention to these gaps and weaknesses in the emergency care systems in our own country and also around the world, that those problems and challenges existed, and this brought some much needed attention to it and gave us an opportunity to get government support, funder support to try to respond to it. Also, this program that we did in Bihar highlighted an important thing for emergency care system strengthening. And as Michelle mentioned, everybody shows up to the emergency department everywhere in the world. And this is something Janis will appreciate this, but one of our mentors, Dr. Terry Reynolds at WHO, what she has always said is developing the emergency care program is that emergencies happen every day, everywhere, regardless of a system's ability to care for these patients. So even if you don't have a properly functioning emergency department, emergencies will still happen. People will get injured, people will get sick, and they're going to present somewhere, regardless if that place is able to care for them. And this is what we found to be hard. People will still show up, and it was up to us to try to, and to all of our partners, to try to build a system that can care for these patients. And also, I think it speaks to our ethos and approach to global health in a larger sense, is that people don't show up to an emergency department on a schedule. They don't show up during business hours, 9 to 5. That's only about 30% of the hours of the week. The majority of presentations and emergencies happen outside of business hours, and we need to be able to care for these patients. And patients don't show up saying, I have tuberculosis and I need to enroll in a tuberculosis top-down study to get randomized into different treatment for an MDR program or something similar than that. People show up and say, I have shortness of breath. It's a presentation-based world, and that's how we try to gear our response towards people presenting with conditions, and how can we diagnose them and treat them regardless of their age, of if it's a traumatic complaint, a medical complaint, a maternal child health, OB-related complaint, infectious disease. People will all show up, and our systems need to be prepared to care for them, and they need to be able to do that in a day-to-day setting, and in a humanitarian setting, in a conflict setting, and even in the most austere settings. And that's really what ties together all of our work, is to ensure that all people in the world have access to timely, high-quality care when they need it. And that's what really drives us. And I think that's it. So we'll talk a little bit about the balance, and I'll turn it over to Michelle to wrap up on how we view our work in a larger sense.
Yeah, thanks, Sean. I think being an academic institution, it's a really fine balance. NGOs or the government or the UN, you could substitute any of those terminologies there, it just didn't fit on the scale, is they're service oriented. Their job is to deliver services to people who urgently need them in a timely fashion, and to stretch as much funding as available. As Sean mentioned way back in the beginning, only 2/3 of the needs that have been identified are likely to be met in this calendar year based on funding. And so the operational side of things has this incredibly urgent mandate to be efficient, timely, and meet service needs. I would say, sitting in an academic institution, that's literally the opposite of our mandate. Our mandate is, academic output, thought policy, education in our trainees, research. And so aligning those two things, where we can deliver education that meets urgent need, where we can do monitoring and evaluation to support demonstrating the effectiveness or adding to the body of humanitarian literature to meet need better and more timely. Using trainees, I think, is a whole topic of its own discussion in a humanitarian context. I think it has to be done incredibly thoughtfully. And then, research for the sake of research, and where that role, where that's acceptable and where it's not acceptable, I think is very contextually based. And so as Sean and I engage in all these projects, we constantly sit back with our teams. Every project we work in is a team. We also work in a very sort of global team fashion. So for example, our Care India project was not just our institutions, but others from around the United States, Europe, the UK, and Australia. We needed a lot of personnel. Same thing with our collaboration in Ukraine. I think we were up to about 175 people we've needed to be in Ukraine. HHI does not have that kind of staffing. And so we work in networks with other people from other institutions to help support the need in a project team. But as the team, we have to sit and balance, is academics getting in the way or hindering in any way meeting the urgent need, which is the humanitarian imperative. And so I think this is something that's constantly on our minds. And so with that, we'll stop the screen share to start taking questions and discussion.
Awesome. Thank you so much to both of you for this super engaging conversation. There are questions that are coming in, and I will get to them momentarily. I wonder whether or not, that last point, we've talked a lot at understanding that most of the people that are on this call are academicians. And can you talk a little bit, maybe a moment, just on how you made arrangements with your university to have some degree of operational capacity, right? And so that balance that you had, how are you able to make arrangements to actually do rather than think or study?
That's a great question. So, we are sort of bound by our employer. So as Sean mentioned in the beginning, the Harvard system is multiple teaching hospitals. So the children's hospital is separate from the adult hospital. So at our hospital, when we started 10 years ago, there was no system. And so we had to build it from the ground up, meaning had to educate our leadership about the importance of this work, the need we're meeting. We had to educate ourselves about the risk and risk mitigation strategies around insurances, working with trusted partners like International Medical Corps or others. How do we have sort of active risk mitigation plans ongoing? And so for us, that was a lot of the work to really build the system. I don't know, Sean, if you want to comment too from your perspective, especially I think on the Ukraine project.
Yeah, it's work. I find the greatest success that we have is when we really identify the shared goals that we all have, and how we're all really working towards the same thing. Our hospitals, and I'd say all hospitals have their a local goal or a regional goal and a mission, but that mission also extends globally. And by really helping people identify that we should be sharing our expertise and opportunities and fulfilling this technical expertise with operational partners, that really aligned our mission across at our hospital and the larger system, and in partnering with the academic institution, which in our case is Harvard, but that will vary with different hospitals. Once you get everybody on the same page, realizing that we all share the same goal and that we do have the tools within our system to achieve it, then it's getting down to the brass tacks of what are the logistics of this. And we found that educating ourselves and our institutions about, as Michelle said, the operational realities, and there's a lot of details that you may not realize at first that go into this, logistics, insurance, funding, movement of money, and reporting requirements, and the partnering with external organizations to complement our academic side with their operational side, whether it's NGOs or UN organizations, has been a really successful model for us and allowed us to accomplish this work. I don't think we could be as effective without our partners. Actually, I know that we could not be as effective without our partners. And that's my recommendation to people listening who are thinking how they could do this at their institutions. Identify the shared goals and then identify good, reliable partners.
Yeah, thank you. I mean, I think that I'll try to kind of lump some of these questions too. I mean, can you talk a little bit about the funding? I know that there's a question about like, where do these funding streams come from and where do you look for them and how do they get implemented in an academic setting? And also, if you were working with NGOs, so is the local NGO deciding sort of the capacity issues and applying for funding, and you are a co-partner, or are you coming in from the United States sort of driving agendas? And so I think that the funding question is really an interesting one because you've talked about even yesterday, right? So the World Health Organization, I think it was $1.5 billion that was going to be done through the development banks of the world to do some of these projects. And so how do universities engage with that funding structure?
It's a great question. I'll start and then I'll turn over to Sean. I think the first is that we're always aligned to someone on the ground's priorities. I think there was a good question in the chat about choosing. We like to say we don't choose, they choose us. And so we've worked to really build a network where different organizations, whether it's an NGO, a country government, WHO, or national WHO levels, kind of know who we are, know what we do, know what we are capable of, and have seen past projects, to be able to say, oh, I need a trauma solution. We should call, Sean and Michelle, or, oh, emergency care. We know some people who do that, or pediatrics. So we try to sort of maintain a network so people know who we are, what we do. And then we try to help support the organization we're partnering with, whether it's IMC at a very international level or, OSAD and Tigray, to put together a program jointly that's, as Sean described, embedded within the system so it's sustainable from the beginning or has some sort of immediate need and transitions responsibly. And then together, we often are part of those funding proposals. And so some organizations are going to the traditional aid funders like USAID or Bureau of Humanitarian Affairs, the European or UK equivalents, or Turkish or Japanese or whoever. And then sometimes we're working more with philanthropic funding, where there's, a more of a nonprofit kind of donor, either individual or a foundation, that's also, again, providing funding. I think the key thing is that we're very transparent about the funding, working with the partners, and we're very clear that we are not a funder, we're a collaborator, and together we seek funding. I think Sean can probably
And
talk a
how
little.
did HHI start, Michelle? Like, how did the university, this is a really unique sort of initiative. And so how did the university kind of look at you guys and say like, wow, this would be a remarkable initiative to sort of like put together sort of these projects?
I think it
I
started.
can answer that.
Turn that to Sean, yeah.
Yeah, so so I don't know if there was people in the founder of HHI, Dr. Michael Van Rooyen, and him and a group of other of his collaborators at the time. They recognized this need. They were working in the humanitarian space and had been for several years with many partners, and they recognized that there was a need to apply evidence-based action to humanitarian response, and they also recognized the opportunity in academia that in Harvard and other systems, this is not just Harvard, I want to be clear, but I mean, many other university systems, that there is an opportunity to leverage the expertise throughout the university to improve humanitarian aid, and pitched it to the university. And like anything, I mean, now it's 20 years on, but when it starts small. It starts with a group of people who are working hard and have a passion and a belief. The funding starts small, and then you prove yourself and you do work. And I think, just to echo a few key things about funding that Michelle said, is some of the most important things is that things are done as partnerships. We don't show up and we never decide what the needs are. That we respond when asked, and then we help look at the data, collect the data, and analyze it to identify the needs, always in partnership with local partners. And we ensure that the funding gets to where it needs to go, that we're transparent with our budgeting and our funding asks and with our different partners, and making sure that the dollars that are funded go to the people who they're supposed to go to, and that they get directly to the care that's needed.
Awesome. I'm going to shift a little bit in the questioning session. So there have been a few questions in the task, and maybe these can be specific examples. And so, when you are working in the humanitarian space, I wonder if you could talk about, we obviously are emergency care providers, but maybe you can talk a little bit about, there are very many people on the call that are focused on sort of immunization, ID, preventative healthcare programs. And so how do you see that? Can you talk a little bit about like the mental health programs? And then I think finally, we have some engineers and we have some lawyers and we have some other disciplines that are on the call where, when you talk about maybe a little bit about the wash and logistics, like the non-clinical piece for some of the other people on the call.
Maybe I'll start with my thought in terms of Michelle to talk, because she's working specifically in some of these areas that you mentioned. But I think of it the same way. I think humanitarian response, it's the same as for me. I'm an ER doctor, but the reality is, on my own, I'm pretty ineffective. So if I was to show up in an ER, I'm just one very, very small part of the puzzle, right? A patient needs to get through the door. They need to be registered. They need to be triaged. They need to be changed. There needs to be a laboratory that can do labs. There needs to be somebody who can draw labs. There needs to be a building that houses this whole thing, that has electricity. There needs to be specialists and all of these things. When you step back and think about it, as using the ER example, as the ER doctor, I'm just 1% of a larger 100% that needs to go in for the care of one patient. Humanitarian response is the same. Healthcare sector is just one small part. A healthcare response is completely ineffective without, you mentioned WASH, without clean water and sanitation and hygiene, without shelter, without security, without access to education, and a long list of other things. And that goes back to that cluster diagram, which I think is a really great way to recognize the bigger picture and to look at that and say, we need all of these components. And that includes engineers, that includes lawyers, that includes teachers, and it includes everybody. Really, I can't think of a profession that it does not include. And everybody needs to be a part of it. And we come to it from the healthcare angle based on our professional backgrounds. But for anybody, it's important to recognize that we're nothing without all of us, and that this response is all about collaboration. And Michelle can maybe talk about some of the mental health aspects and other specific aspects.
Yeah. From the infrastructure aspects, even the question of vaccination, there's a great question about polio vaccination, which is a current challenge in Gaza right now. This is a repeat challenge from 10 years ago. So I was part of the Syrian polio vaccine campaign when polio reoccurred in Syria in 2014. And, some of the challenges there was access and negotiation. There was a humanitarian pause that allowed the logistics system. You need a cold chain, you need trucks, you need movement to get vaccines where they need to go. In a response where we have access, vaccines is usually on the front leading end of response for exactly that disease prevention. It's much easier to prevent tetanus than it is to treat tetanus. If anybody's treated tetanus, it's painful. And so, I think the vaccine component is critical. The infrastructure piece, as Janis introduced, I spent a year and a half running the government hospitals for Ebola in Liberia. I did about this much doctoring. I did about this much water and sanitation. If you don't have running water and you don't have sanitation facilities and you can't destroy your sharps, you're just transmitting Ebola over and over and over again. And so the engineering team that we work with, we actually worked with the government's Ministry of Public Works to bring in water sanitation experts, repair that infrastructure, deal with kind of the issues around that. There's a question about electricity in the chat. Depending on where we're working, all of our teams are ready for no electricity. This is a really common problem. So that bomb shelter picture that Sean showed, Catalina has the luxury of the power's on, and so the PowerPoint was working. But essentially, the way we mitigated that plan is every participant had a manual, and had the power been off, we would have continued teaching just using the manual, and the teacher has the guidebook and would continue sort of just verbally teaching. And so we make sort of layers of backup plans. I think the mental health piece has been extremely under-recognized. I think it's just finally hit the forefront. It's another, I'd say, COVID silver lining, in that COVID shined a light on the mental health suffering that many people are undergoing, and in particular in the humanitarian setting. So these programs are just rolling out. Mental health has sort of a pyramid approach where there's, peer level services, community level services, but there's very, very little treatment level services, meaning actual counseling or therapy, or specifically medication management for things like severe depression or psychosis, or significant adjustment or conduct reactions. And so one of the challenges we have is really workforce and mental health. And so prescribers would be a really key asset. And I think that's where bringing in the multiple professions is really huge, social work, case management, et cetera. I think this does, we had some other questions in the chat. This work does differ significantly from Peace Corps, and the fact that that's stable development work. This is much more complicated system, where the systems are failing oftentimes. And so we're bridging the gap between stable country development and humanitarian response systems, which are structured externally. So I think that's kind of we need everybody, as Sean said. The more the better. I would have killed for an engineer or two during Ebola, but we made do. We had our public works team, and they were amazing. So I'll turn it back over to Janis.
Awesome. Thank you. I really appreciate it. Thanks so much for all of your questions, everyone. Really engaging conversation. I encourage you guys to look at HHI's website and their social media platform if we have interest. And so appreciate all of everybody's time. I'm going to turn it back to Kaylin for a moment.
Wonderful. Thank you, Janis, for your moderating, and everyone, if you could please join me in thanking Michelle and Sean for sharing their invaluable insights, and congratulations to you all on your incredibly impactful work. We truly appreciate the time you took this morning to share everything that you're doing, just based on the comments and questions in the chat today. I know everyone really appreciates this engaging discussion, and also want to thank the audience for joining today and sharing your questions. Our next Global Health Tuesday webinar is going to take place on Tuesday, October 29th, where we will discuss bird flu in cattle. So be sure to check out our website, ghi.wisc.edu, to find today's archived video and learn more about our ongoing activities. I hope everyone has a wonderful rest of your day, and see you next time. Thank you.
Thanks, everyone.